exciting session on transfusions. My name's Emma Borcock. I'm an intensivist from Sydney, Australia. And I'd like to introduce Jacques
Jacques Duranteau from Paris. It's a pleasure to moderate this session both together. And maybe you can introduce the first speaker.
Exciting. I think Mervyn Singer, Professor Mervyn Singer needs a little introduction, but he is a Professor of Intensive Care Medicine at University College London. I'm very excited to hear this talk.
Thank you, Emma. Hi, good morning, everyone. There we go, history of blood transfusion. This is hopefully a fun lecture. I enjoyed putting it together, and it just basically shows me what people did many, many years ago and the pioneering spirit. Okay, so every 3 seconds someone in the world gets a stranger's blood. In the United States, apparently 16 million units of blood are transfused into 10 million people. The first person, he was thought to advocate transfusion, but he's not known to have performed it, was give blood from a young, fit, virile young man to an old, feeble man, and then that person will be reinvigorated. Seems like a good idea. And you can see here, so he suggested joining the artery with a tube from the young man to the old man, giving him this revitalizing blood, and there the hot and spirituous blood of the young man will pour into the old one as if it were from a fountain of life, and all of the old man's weakness will be dispelled. But he is not known to have done it. But the story moves on to this guy, Sir Christopher Wren, who was a very famous architect. He designed St. Paul's Cathedral in London, and he was a bit of a polymath. He did lots of experiments on animals. And this is the History of the Royal Society from 1734, 4th edition. Christopher Wren was the first author of the noble anatomical experiment of injecting liquors, not liquor, alcohol, liquors, fluids, into the veins of animals. It's been presented to meetings at Oxford and then taken by Germans and published abroad. By this operation, various animals were immediately purged, vomited, intoxicated, killed or revived according to the quality of the liquor injected. Hence arose many new experiments, chiefly that of transfusing blood, that will probably end in extraordinary success. Wow. So he set things up to actually then start thinking about doing it in man. And the French got there first. There's Jacques. Jean-Baptiste Denis, who was the physician to Louis XIV, in 1667, in June, you have to remember June, a 15-year-old boy who'd been bled excessively by leech therapy and was very weak and feeble, and Denis gave him 350 mils of sheep's blood, and the boy recovered. And then he thought, wow, this is good, let's do a few more. His second patient, who was a labourer, also recovered. Unfortunately, the third patient, who was a Swedish count, died after the second transfusion. He then tried again on a fourth patient who had neurosyphilis. He believed it would cure him of his syphilis, and after the third transfusion, the patient died. He was charged with murder, but acquitted because it was found the guy's wife had poisoned her husband with arsenic. However, it didn't look good, and so France banned the practice in 1669. A few months after June 67, it was done in England. Richard Lower in front of members of the Royal Society. And there's the manuscript, and that's actually the apparatus he used. And he got a volunteer, Arthur Koger, who was paid 20 shillings, that's £1. In those days it was a bit more money. And he transfused about 270 mils of sheep's blood to cure this guy's mental instability. Seemed to go fine, no problems. He repeated it again. On the 12th of December, Koger was an alcoholic and he actually liked the money, so he said, I'll come again. However, they were planning to do it a third time, but it had to be stopped because Koger claimed he'd been transformed into a sheep. So England banned the practice in 1680, and I think the Pope Innocent, whatever, one of the Pope Innocents banned it soon after. So nothing really happened until 1818. So this is James Blundell, who was, I think, an obstetrician at Guy's Hospital. And he gave the first human-to-human blood transfusion in that year. And this is in the medico-chirurgical transactions, a case of obstinate vomiting in which an attempt was made to prolong life by the injection of blood into the veins. And this man, Brazier, in his 30s, lately a patient of Guy's, had pyloric stenosis, and he'd been vomiting most of his food for 3 to 4 months, and his dissolution, his death, was expected any hour. The veins of the limbs were evidently shrunk, the pulse was small, feeble. It could be counted with difficulty. The vascular system seemed nearly empty. Some gentlemen present, there was other doctors, basically each donated 1.5 ounces of blood. And that was taken up into a syringe and immediately infused into a vein in a gradual stream. This was repeated 10 times, so in total 12 to 14 ounces of blood. So that's about 392 mils were given over 30 to 40 minutes. Basically, they didn't really see much happening, neither bad nor good. Everything, temperature, heart rate, nothing really had changed. However, at the bottom, the blue discoloration of his hands, already described, gave way to a more healthy complexion. This was performed about 2, 3 o'clock in the afternoon, but by the evening, he was looking much better. His body had become warmer, respiration regular, pulse had nearly doubled its former size, beat with great regularity, 88 times a minute. And the patient himself said, "I'm feeling better, much better, less fainty." And he was saying this in a stronger voice than he'd heard him use before. Interestingly, he commented, "Well, how much blood should we give these people? It's hardly necessary to remark. It would have been unwise to throw a large quantity of blood, for example, 2 or 3 pints. So a pint that's about 1.5 litres into the veins at once. The patient was exhausted, the heart vessels were feeble, we had no former experience of how much to give, etc. So it further proves, at least with all the force of one single case, that the infusion of human blood by a syringe is not dangerous, provided you don't leave the blood to settle in the cup. Don't let it clot. Give it within a minute. No unfavourable change was produced, and the guy actually died 50 to 60 hours later. Whether it was the pyloric stenosis, whether it was a late reaction of the blood, we don't know. Anyway, Blundell was encouraged, and then in 1825, he reported in the Lancet a case of a woman having a postpartum hemorrhage. And essentially, this was very severe. And this was at her home, and when she was visited, her pulse was barely palpable. Often it couldn't be felt. The lips and face were of a pallid, a pale, death-like hue. And in a word, the taper of life, the candle of life, was faintly glimmering. Why can't we write like this anymore? It's boring, aren't we? God, we're boring. And basically, he needed someone to give blood. Her husband. He was a robust, stout, healthy young man, and he was called in and gave 2 ounces of blood, and he put it into a glass tumbler, and he made a little cut into her vein, and with a syringe and tube, injected the blood from the husband slowly towards the heart. No obvious effects were produced, but after a pause of 1 or 2 minutes, 2 other ounces were thrown in. So not much, 112 mils. And then 5 to 10 minutes later, she began to look better. Then she carried on improving, and not a single bad symptom or side effect could be attributed to this blood donation. And he admitted that it might be questioned whether such a small quantity of blood really saved the patient. The doctor, and who'd seen lots of hemorrhage, was decidedly of the view that this timely supply of vital fluid turned the scale in the patient's favour and rescued her from death, and she survived. And a few years later, he wrote up a case series of 10 patients with postpartum hemorrhage, 5 with good outcome, and that was actually from the paper. Beautiful, isn't that a beautiful diagram? 1828. Let's move forward. Again, it didn't really catch on. It sort of died a death. There was, presumably, things were happening, but there were reactions. 1906, this guy, George Cryle, at the Cleveland Clinic. Again, he'd been doing experiments giving blood to dogs, finding good results with hemorrhagic shock. And this is a young man who was having an operation for kidney stones. And basically he was bleeding. The hemoglobin had fell to 25, the heart rate 160, respiratory rate 48, gasping. He was unconscious. And they tried postural, lifting these legs, bandaging, saline, stimulants, adrenaline, all to no avail. It was clear that this guy was soon to die. Everything they tried didn't work. He seemed, therefore, a suitable sort of last-ditch rescue case for transfusion. A willing donor in the person of his brother was at hand. And they basically put a tube from the artery of the brother to the vein of the patient. And blood was allowed to flow steadily for 30 minutes. As a result, the patient promptly came out of his unconscious state. Heart rate, respiration rate fell, blood pressure rose to 94 millimeters of mercury, hemoglobin came up, and in his brother, the hemoglobin fell from 100 to 70. There's another account of somebody who was there, his wife, Mr. George Cryle's wife, saying that they were looking at the patient, not the brother, and they had to stop because the brother had fainted. And then basically the patient was in such good condition that they then carried on with the nephrectomy, which was performed well. This is the patient in 1962. His other brother had also given blood. So there they are showing their sister, look, these are the scars. So nice story, eh? Okay. Again, the medical establishment didn't really take kindly to the idea of giving blood. So this is in the British Medical Journal the following year. A paper by Dr. Cryle giving the results of his recent research seems likely to arouse renewed interest in a subject that for some years had lost much of its potential or practical importance. In the normal animal, it was found raises and sustains blood pressure more so than saline. This is in hemorrhagic shock. Excellent results were certainly obtained in some cases of shock, but in the treatment of this condition, and indeed of all others in which intravascular infusion of some kind is clearly indicated, surgeons, we imagine, will find no good reason given here for abandoning the safe and simple method of just giving saline. So it didn't catch on. Interestingly, when you go to transfusion reactions, Landois, who was a Frenchman, had worked out that if you put incompatible transfusions together, the blood clumped and hemolyzed. Though it wasn't until Karl Landsteiner in Austria worked out ABO blood groups in 1901. And this guy, Reuben Ottenberg in New York, gave the first ABO-matched transfusion to a patient and identified that you could give group O blood to anyone. And he later reported in this paper accidents in transfusion in 128 cases in 1911. And things then accelerated. A Belgian, hey, good for Belgium, Albert Oestin gave the first non-direct blood transfusion using citrate as an anticoagulant. So rather than going straight from brother to brother or husband to wife, now you could put it into bags, anticoagulate it, and then later give it. The following year, Louis Owen in New York optimized how much citrate to put in the bag to, as it were, give the optimal dose in terms of prolonging the anticoagulant effect. And at the same time, Weil, also in New York, worked out that this citrated blood could be refrigerated. So that was the genesis of blood banking. Around that time, there was a little war going on in Europe. And again, blood banking, it took off. Again, not spectacularly, but by the end of the war, many of the Allied troops, British, American, were using blood. And you can see this report in The Lancet, 1918. In cases of severe primary hemorrhage accompanied by shock, blood transfusion frequently produces an immediate, almost incredible improvement. I'm looking at the time, I'm late. Coombs test came in 1945, so they were still getting reactions, so it didn't really take off. By the Second World War, this came out just afterwards. It was a report on effects of injury into man during the Blitz, and then 5 years later in the front line in Italy. At the early days of the war, they weren't using blood. So patients who had been injured, shocked, were put head down, morphine was given, they warmed the patient up, and they often felt uncomfortable. They left him clothed because he didn't want to disturb them. They gave them choramine, which is like adrenaline, oxygen. That was it, that was the management. They only gave transfusion as a last resort and then only in small amounts. Didn't use it prophylactically. It was considered dangerous to give. It would renew bleeding, and the surgeons wouldn't like this. If you gave too much, it would overburden the circulation, dilate the heart, cause pulmonary edema. You got reactions. But by 1945, they'd realised actually blood was a good thing. Most important, transfusion was given earlier and more freely, and they found that if you give it too slowly and hypotension allowed to persist, even after late large transfusions, it was too late. You have to get in there early and give adequate amounts. So how much? They worked out that actually giving more blood to these patients was beneficial. Case H115, by the 5th day, he looked well and felt champion. And they commented on 3 cases, got more blood and did less well. And how much? And they worked out just getting the blood to a blood pressure of 100 millimeters wasn't good enough. Often the patients collapsed if some little tiny insult happened thereafter. So he basically argued, Grant, that patients who were thought to be over-transfused did better than others. It then took off. This is in the Second World War. You can see the amount of blood being used in the theatres of operation, European and Pacific. 1 month, 60,000 units. Last couple of slides, sorry for running over. Just about safety. Basically, with typhoid or yellow fever vaccines, basically there was a huge outbreak. 330,000 servicemen got infected and 1,000 died. And basically it was human serum that came from medical and nursing staff at Johns Hopkins. And obviously some people there were carrying what was eventually found to be hepatitis B, but that wasn't identified for another 20 years. But then blood testing was developed, and by the 70s, the FDA mandated all blood be screened for hepatitis B, measles, malaria, and syphilis. Then hepatitis C came along, and then HIV came along, and clearly, sadly, lots of people died as a consequence of this tainted blood transfusion. But since 1985, apparently all blood has been clean, certainly at least in America. So I'll finish with this quote from Goethe. Blut ist ein ganz besonderer Saft. Blood is a special fluid. Thank you for listening. Sorry to overrun. Shall I go off? I've overrun.
Truly wonderful run through the history. It always amazes me how long it takes us to learn from the lessons of history and then to even more to then refine practice. Indeed. It was a really wonderful talk. Thank you.
Thank you very much.
Do we have any questions for Professor Singer in the audience? We might move on to our next speaker.
Okay, so it's my pleasure to introduce Gavin Perkins. Gavin will talk about pre-hospital blood transfusion.
So thank you very much, and thank you, Mervyn, for an excellent introduction to the session. So I'm going to focus on the use of pre-hospital blood transfusion. I've just got a short slide outlining my conflicts of interest, other than having received research funding for the refill trial, which I'll refer to during the course of the presentation. I don't think that there are any relevant conflicts of interest. So the context for pre-hospital transfusion is that major trauma affects millions of people around the world year on year, with about 5 million deaths being attributed to trauma each year. And within that cohort of deaths, a third are attributed as a consequence of hemorrhagic shock, where early intervention with blood and blood products has the potential to reverse or reduce some of that morbidity and mortality. So blood products have been a cornerstone of modern day resuscitation. We heard in Mervyn's talk the evolution of the transfusion of blood to now large trials demonstrating, at least in a hospital-based setting, that balanced transfusions improve the outcomes of patients with hemorrhagic shock. But the key question that remains in, I guess, the modern healthcare setting is whether projecting that intervention into the pre-hospital setting is likely to be clinically and cost effective. So I thought I'd start by looking at European practice, and this is a survey done by Carl Thies and colleagues a couple of years ago, and shows some of the variability that is seen across Europe in terms of the pre-hospital transfusion practice, both in terms of whether it is practiced, but also the components that are used. So over on the left-hand side shows the significant inter-country variation, and the right-hand side demonstrates the key interventions that are used in the resuscitations of patients with trauma-related hemorrhage and shock. So tranexamic acid being the commonest intervention, and then just less than 50% of respondents reporting the use of packed red blood cells, with a lower proportion using plasma and lyoplas. The mode for getting blood to the scene was also variable. 50% of respondents carried it on their primary response, which was, in most situations, a helicopter. And this is important when you're thinking about the time that it potentially takes to get blood to the scene. 40%, by contrast, were relying on dispatch of the blood from a hospital or from a central repository using secondary transport, which is obviously going to have an impact on the speed with which the interventions can be delivered. Even if we look at a single country, so Caroline Leach recently surveyed UK air ambulance practice, and even within the context of a single country, you can see that there's significant variation from mixed product, packed red blood cells and fresh frozen plasma, through to using only packed red blood cells or plasma-only resuscitation. And I guess this variation in practice is largely driven by the uncertainty of the evidence informing the use of pre-hospital blood. Further variation in the approaches or the identification of cases that are likely to receive pre-hospital transfusion. This is a separate scoping review of current practice across Europe, published in Transfusion Medicine, and it shows a range of different indications that are used by pre-hospital systems for transfusion. These can be broken down into evidence of hypotension and hypoperfusion, to the effects of those in terms of discoloration, change in mental status, and the important role that clinician judgment plays across a large number of those settings. So this slide summarises, and there have been one or two more recent systematic reviews and meta-analyses, but they face many of the same challenges that this systematic review and meta-analysis contains, and that is the significant heterogeneity in the design of studies. There's a mix of observational studies and randomized controlled trials that are often mixed together in the meta-analysis. The context for pre-hospital transfusion includes both a civilian and military setting, where I think both the case mix and the capabilities of those delivering pre-hospital transfusion are notably different. And then there's geographical variation in terms of where the interventions have occurred. And although many of the systematic reviews present meta-analyses, I'd caution that the heterogeneity places some methodological limitations on interpretation. So what I thought I would do, rather than present a series of meta-analyses, is to just present some of the key trials that are currently informing practice. So one of the earliest large evaluations of pre-hospital blood transfusion came from the US military, from Shackelford and College during the Afghanistan conflict. In this trial, pre-hospital medical evacuation teams were responded to people that had sustained significant traumatic injuries. And inclusion here was that someone had to have sustained a major traumatic amputation, so that would be an above elbow or an above knee amputation affecting one or more limbs, or that the person had severe hypotension and tachycardia. There's some key characteristics about the military context, and that partly relates to the case mix. These are young, fit soldiers that have often sustained compressible hemorrhage, as is the case when they sustain amputations. The emergency response also delivers an enhanced care team to the patient rapidly, and US standards required that somebody injured in the field had to be delivered to a trauma centre type equivalent within 1 hour of injury in order that it reflected what would be provided in civilian practice. So the whole organisation of military services was around rapid deployment, rapid intervention and rapid transfer on to definitive care, something that's more challenged in the civilian setting. What they were able to demonstrate was both the short-term mortality benefit at 24 hours, demonstrating low mortality in patients who'd received pre-hospital transfusion, and this effect, you can see the Kaplan-Meier curve separating fairly early within the first few minutes or hours of intervention, and these are then sustained through to 30 days. I think it's worth noting the overall mortality rates here are really strikingly low. That's less than 2.5% mortality in people in the pre-hospital transfusion arm. And in the context of study, this was a cohort study as opposed to a randomized evaluation. They also demonstrated the time-critical nature of pre-hospital transfusion, with there being significant benefit confined to patients who received pre-hospital transfusion within 15 minutes of injury, shown on the left-hand side, and on the right-hand side if the pre-hospital transfusion was started greater than 16 minutes. So moving from the military setting, where I think it's difficult to translate through to the civilian setting for some of the reasons outlined, this was the PAMPA trial, which was a trial that it's a cluster randomized trial, randomized patients to pre-hospital plasma in a US civilian setting. Patients a little older, case mix very different, 80% blunt trauma. And patients enrolled in this trial would receive either 2 units of plasma as the intervention, in addition to the standard of care, which included saline and the ability to receive packed red blood cells. This study showed a significant improvement in outcomes in patients who received pre-hospital plasma, and several of the secondary outcomes that I'm not going to drill into now also demonstrated improvement in outcomes. Translate that across to a different setting. This was the combat study. Here, plasma was delivered by paramedics in the out-of-hospital setting. The case mix, again, different from the military setting, predominantly blunt, higher injury severity score. The intervention here, similarly, 2 units of plasma. This study was stopped early because of futility and a failure to demonstrate any improvement in any of the relevant clinical outcomes. Looking at 2 post hoc analyses from these studies, there was the PAMPA and COMBAT trials pooled their data in order to look at the impact based on time of transfer to definitive care, demonstrating that the benefit or the potential benefit came in patients that had a prolonged transfer time to hospital. And similarly, a post hoc evaluation of the PAMPA trial demonstrating, or at least suggesting, that the combination of packed red blood cells and plasma were beneficial. So these trials set the scene for the UK-based Refill trial. This was a trial that recruited severely injured patients in a UK pre-hospital setting, noting that the injury severity scores are 2 to 3-fold higher than in the previous studies. Unlike the previous studies, tranexamic acid was initiated in the pre-hospital setting in the majority of patients, but reflecting again the UK context, there was a significant response time and time to intervention and onward transfer to hospital. So the Refill trial found no difference in the composite outcome of episode mortality or failure to clear lactate, or on the second line there, the individual components of those, and death occurring within 3 hours, a 6% difference pointing in favour of pre-hospital intervention, but not something that reached statistical significance. I'm going to quickly run through a series of slides now looking at some of the physiological effects. So we saw no improvement in tachycardia, no improvement in physiology, systolic blood pressure here, or in lactate concentration, either at the scene or upon arrival into hospital, and no difference in the INR upon hospital arrival. What was striking was the proportion of patients that arrived with a hemoglobin of less than 80. It was relatively small. It was just 0.6%, but only in the intervention group, but only 6% in the saline group. The only difference that was observed in this study was that the pre-hospital intervention group, and this has been seen elsewhere, had an overall total transfusion intervention that was greater in the control group. No differences in a variety of subgroup analyses that were defined either a priori or afterwards. The transport time and the injury severity similarly showing no significant interaction. So where does this leave the field? I think this leaves the field that pre-hospital blood transfusion has been widely implemented in the pre-hospital setting, but the evidence base informing that is still evolving. The UK under Laura Green and Jason Smith have recently launched the SWIFT trial, which is comparing current pre-hospital transfusion practice to the potential benefits of whole blood. So in a way, linking back to Mervyn's talk about those person-to-person transfusions, almost completing the full circle from components back to whole blood. And we hope that this study will be reporting in the next 2 or 3 years. So in conclusion, I believe that uncertainty continues to exist in relation to the role of pre-hospital blood transfusion. I think that within the studies there are some signals of benefit, but often the confidence intervals are wide. I think that there's still uncertainty about case selection, the patients that will most benefit from pre-hospital transfusion, and the combination of interventions that are likely to be most beneficial. And I think the patient characteristics of those who will benefit require further elucidation. Thank you very much for your time and attention.
Thanks a lot for this very nice talk. Do you have a question or comment? Yes. I don't know if there is a microphone.
If you're at the front, I'll repeat your question.
Oh, yeah. No, so great talk, but I think one of the things you're also pointing out is those observational studies, there are major flaws. I mean, even also with the ratio studies, there was a 66% reduction in mortality in the combat setting, but the PROPER trial was a negative trial, which did not show the effect. So, in a way, I love the study, and it showed you need randomized trials in this setting, you can do it, but should not be the conclusion we should get the blood products off the helicopter. We have a huge shortage of blood products. We do a lot of waste in this setting. So what's your comment on that?
So I think the question is that the randomized control evidence, which is better evidence than the evidence from observational studies, hasn't demonstrated benefit, and should we therefore be taking the blood products off the helicopters until we've got such evidence, because blood products are short thought. And from an evidence-based and I guess a clinical practice, perspective, I'm aligned with, your thoughts that we don't have the robust evidence in order to be able to demonstrate the benefits of pre-hospital blood transfusion. But we're in a context where the motivations of interventions are not necessarily evidence-based medicine, and this will probably be, controversial to state in a public forum. But certainly in the UK, helicopters are based upon charitable contributions, and it's a great platform to advertise for fundraising, to be introducing an intervention that seems inherently attractive, that it's delivered in the hospital setting. So the weighing up of evidence in the UK that the NHS might do sits in a different domain in the UK context for helicopter-based practice. So when you're faced with the situation that now all UK platforms carry some form, that it's difficult or impossible to wind back the clock. I think that that's where the SWIFT trial will be helpful, that it's accepted that the horse has bolted, as it were, but nevertheless, based on that wide, variation, whole blood is a new intervention. Is that going to add incrementally?
But whole blood is, of course, based on the same bias and it was the ratios.
Yep. No, absolutely.
Just one question is the fact that it's not possible to prove, to show a difference. Could you think that it could be due to the fact that on scene it's very difficult to have a clear idea of who will be benefit of the red blood cells? So, and I'm completely agree that if maybe the priority is not to lose time during the transport time, because looking at this different trial, the transport time is quite different, and especially in UK, and it's the same in France. It's, in my point of view, it's very long.
And I think where you've got longer emergency response and transfer times is, I think absolutely the priority needs to be to mobilise and transfer patients as rapidly as possible. But there are geographical constraints and limitations that physically prevent you being able to get patients into an emergency care setting in the way that some of the military studies have done. I guess if pre-hospital transfusion is going to have a role, then it's in those cases that have a longer transfer time to receive definitive care, and that may be based on geography, or that may be based on the person being physically trapped and you're unable to move them initially. I absolutely agree about the point in relation to patient selection, that we've got very blunt tools at the moment to determine which patients will benefit from pre-hospital transfusion, and whether more advanced point-of-care monitoring, the use of lactate, other assessments may help us to identify the cohort of patients, who would potentially benefit.
Thanks a lot. We have to move on. Thank you.
Thank you.
It's my pleasure to announce our next speaker, who is Professor Alexander Vlaar, who is from the intensive care. He's a professor of intensive care medicine at the Academic Medical Center in Amsterdam. Thank you.
Yeah, so thanks for the invitation to present preliminary data of the input study, international point prevalence study of intensive care unit transfusion practices. So I think transfusion is a very interesting field, and the previous presenters also highlighted the history of transfusion, because it was actually that begin 1900, everybody was dying when we were giving a transfusion, and by the identification of the blood groups, rhesus, compounds, we were able to at least let people survive blood transfusion. And that resulted in that it looked like a very good intervention, because in the same time physiology was learning that if you would like to optimize oxygen delivery and your cardiac output is impaired, you might compensate anemia with hemoglobin. So it looked like the perfect intervention and to improve patient outcome. But we also know that in the past decades, all the trials show that actually a restrictive transfusion policy is safe, and I think we're still in the area that we are interested in how low can we go in our ICU population. But next to doing all those trials, it's of course important to measure the temperature, how the world is handling with all those new data. So I've got no conflicts of interest, and this is the background why we are interested. We've got the ABC study, which was in a way the same kind of temperature measurement worldwide. What was the red blood cell transfusion practice? 37% of ICU patients worldwide were being transfused. The CRIT study in 2004, 44.1%. But in 2012, an audit was done, and there was already a reduction based on the restrictive transfusion strategy studies being performed. First, of course, the TRIC study with, of course, still question mark. It was not yet leukoreduced, but then, of course, all the confirmation studies came in septic shock, in cardiac surgery, many settings in the ICU where it turned out to be restrictive. And I think that reflects also in 2012 this restrictive policy. But we have been going on and moving forward with new studies, such as the Reality trial, also showing in patients with acute coronary syndrome what we thought would never be true, but a restrictive transfusion policy is safe. And if there is anything, it's a trend towards harm in a liberal policy. So the other thing what we know is that there is a high variance in transfusion practice, and that's good to investigate. We already showed in previous surveys worldwide that practice difference, especially regarding transfusion in subgroups such as acute coronary syndrome, traumatic brain injury, or ECMO, where still this hypothesis is, which came from physiology, if oxygen delivery is impaired or your cardiac output is impaired, maybe with a correction of your anemia, we will improve our patient. So, and we also have been performing Isicem guidelines on transfusion, the first in critical care transfusion guidelines, and we also wanted to know what the impact was that on worldwide transfusion practice. So, and this again, this is our idea about transfusion. We have our DO2 critical, and we often think that this critical DO2 is around this 7, but probably we can go much more down. Weisskopf already showed in JAMA we can go down to 5, 5.5, and no issues occur. So I'm really challenging the person to start doing a randomized trial going even as low as 5 grams per deciliter. I think there is place in the ICU setting. So the other thing is there are some limitations in the previous cohort studies, sample size, sometimes it's just in one country. Often it was focused on just one blood product. What the other issue was is that there was data collected on the practice of transfusion, but the reasoning why physicians were giving a transfusion was lacking. So this is something which also we wanted to solve in the input study. So again, why are we also interested? Several randomized trials have shown the safe use of a restrictive hemoglobin threshold for red blood transfusion in the ICU. And where are we now? What are the current transfusion practices, including thresholds, triggers, and reasons in patients admitted to the intensive care units worldwide? So our primary objective, but I will only go into detail now on the red blood cells because of time, the number of red blood cells, platelet and coagulation factor products in relation to hemoglobin levels, platelet count, and INR, PT, and clinical parameters. We also look to evaluation of the reasons, so why are physicians transfusing, which clinical trigger, which physiology trigger they are using to start a transfusion. And of course, we want to look at subgroups, patient categories. We also know whether it was an anesthesiologist by background training or an internal medicine resident, all those kind of things we can look at, as well as age groups. So what did we do? We had pre-scheduled inclusion weeks in which a week time all newly admitted patients were enrolled with a 28-day follow-up time. Initially, we had only 8 weeks that we were going to do, but then, of course, COVID-19 came, and we had to extend a bit to get the enrollments we wanted. So all new ICU admissions, and what you see here on the right is that each 24 hours a daily case report was filled in, whether the patients were transfused, but also that's new compared to the previous studies, we were enrolling also the non-transfused patients. And if there was a transfusion, then a questionnaire was there for the prescriber to understand why he was transfusing. So we have the demographics, we had the daily questionnaire until 28 days or ICU discharge. And again, separate questionnaires for every transfusion event. So if a patient was being transfused 2 times in a day, there will be 2 questionnaires. So this is the coverage worldwide with a total of almost 4,000 enrollments within approximately 233 centers in 30 countries worldwide. So we are now focusing also in the main results on the red blood cell transfusion. Why do they prescribe the transfusion, and our hypothesis is that still there's a huge variation in reasons, triggers, and hemoglobin thresholds used. So this is again what we wanted to do. So here are the baseline results. So what you see here is that there is still in the transfused and the non-transfused, you see that there is still actually a high percentage of patients being transfused. It didn't reduce that much, and you see still those basic physiology concepts that patients with acute coronary syndrome or ARDS are being more liberal transfused, failure to wean, septic patients even are being more liberal transfused compared to the others. And these are the mean hemoglobin values and the lowest hemoglobin values in the transfused on average on 7.6 gram per deciliter. So total patients are being transfused, a median of 4 units, 80% is still receiving platelets, 28% of the patients worldwide are still receiving plasma transfusion, and luckily, at least at those sites, we enrolled the massive transfusion protocol, and transfusion in an ICU setting is luckily still limited. If we look around continents, this is also interesting to see the differences of hemoglobin thresholds being applied, having in Africa and Asia and Latin America a relatively liberal transfusion policy still, while in Europe and Oceania, which is also taking into account Australia and New Zealand, there is a much more restrictive transfusion policy already implemented. And here's also the reasoning. So we have 24% of the patients being transfused, so what I was already referring to. In that way, we have been stabilized. We are not going down more than we have been doing previously in the timeline we have been seeing. Maybe the results of the recent trials in such as acute coronary syndrome have not yet been implemented, and this is interesting to see. Here you see also that the majority is still using hemoglobin just as a trigger, so we are transfusing just based on the trigger, but there are also many other things taken into account. If the patient is bleeding, and I think also interesting is in the pink, hemodynamic instability being a factor for starting a transfusion, but also still improving general status or improving peripheral oxygen delivery. I think concepts which are in a physiology book very interesting, but they are not taken into account the downside of a transfusion. So this balance we still need to look at. The other thing is, was there a physiology trigger that made the bedside physician to think about doing a transfusion? And here's what you see. There are many triggers still on tachycardia, hypertension, which are triggering a physician in the setting of an anemia to start a transfusion. This is another interesting analysis the group has been doing. Here you see on the x-axis the lowest hemoglobin before a transfusion was going to be started, and on the x-axis the probability. And all the dots are the centers, some larger dots, some larger centers. But what you see on general perspective, if the patients have a hemoglobin of 10, you will not find many centers that have a high probability to be transfused. On the left, it's unadjusted for patient characteristics, but on the right side, it is adjusted for patient characteristics. And then what the interesting setting is if you are at this hemoglobin of 8, there is a huge spread that in hospital A, you have just almost a 75% likelihood of being transfused in general on a hemoglobin of 8, independent of your underlying disease. So I think we have still a lot of work to do to implement the knowledge we have from all the randomized trials work we have been doing. And I think it's also reflecting on the previous speaker discussion we had. We have the trials, but then we have this feeling we still want to do something as a physician, and it's very difficult to not do something if a patient goes bad. So I think the occurrence is in line with the previous large cohort of the ICON. We have a decline from the previous study, the ABC study, but actually there is now some stagnation. So a wide range of reasons, triggers and thresholds are being applied with little evidence, because also the trials trying to find an alternative for a hemoglobin trigger failed all to show that either lactate or SVO2 or an other trigger would be superior. So I think what are the consequences of the study? I think we really have work to do to implement the knowledge we have in the centers where still a very liberal transfusion strategy is being applied. So I think the strength of the study is one of the largest prospective cohort studies this far worldwide, focusing on multiple blood transfusions. Of course, we're happy to share in the future also the plasma, platelet, also the coagulation factor use worldwide in ICU settings. The other thing is, of course, the interest in that we know now what the reasoning is in hospitals. So in that way, we can give feedback on where education and implementation of trials needs to be done. And almost all patients included, we had a very low dropout of no informed consent, so I think we have a reduction of selection bias. What you saw, of course, in the geographic worldwide spread, it's a very nice line in the middle, so it means we have the mid to high income countries. We were able to enroll also North Africa and Asia, but really the low income countries, we have a short enrollment there. So that limits the transferability to this size. On the other hand, there is a different transfusion product and blood banking system often there, but it's good to mention. And the other thing is we are limited with the hospital characteristics, which maybe also be influencing the outcome per site. So conclusion, red blood cell transfusion to focus on, there's no further decline in percentage of patients being transfused, despite new trials showing that in several areas we can be restrictive in transfusion of red blood cells. There is a substantial intercontinent and intercenter difference, and I think this is the basis for future education, implementation of the existing evidence we already have. It was a great work to work with this Isicem endorsed study with a steering committee, with special thanks to Jorinde Raasveld, Sanne de Bruin, in running this huge trial worldwide and having all those enrollments done. Thank you.
Thank you very much. That was a really great talk. Do we have any questions for Professor Alexander Vlaar?
Just a comment. I'm very impressed by the fact that tachycardia and hemodynamic instability is its main parameters to transfuse.
Yeah, so it's a starting point. So it's a trigger why a physician starts thinking, maybe I need to check what the hemoglobin is in this patient. But then what you see is that they have a relatively a low threshold to start already a transfusion. And I think there is this observation bias, because if you give a red blood cell transfusion in a hemodynamic unstable patient, maybe there is a preload issue, and you will solve that. But of course, we know from the trials, it is not improving the outcome. And we need to be cost effective, I think, in the healthcare system, and think about the potential burden for the donor, but also the recipient in having a transfusion side effect.
Thank you very much. I just have one small question. You mentioned about trials that might compare even lower restrictive strategies, sort of 5 versus 7. Do you think there'll be enough equipoise for those kinds of studies? And of course, there'll be important exclusion groups in that. But
well, I think the story goes over there again, as have been done from the 1990s. We start then probably in the general ICU with no acute coronary syndrome in the non-bleeding setting. And I think there we should start with a pilot trial. And then we will see, because what have been shown is that you can go down that low, and then people, if you put them on exercise or you put them on chest games, they start becoming a bit less performing compared to the patients or the volunteers on a higher hemoglobin. But you can argue, of course, whether a patient in an ICU needs to be able to play a chess game, and maybe if it's sedated, maybe it is doing okay with just a low hemoglobin.
thank you very much.
Thank you, Alexander. So, my pleasure to introduce Michael Reade about a very important topic, the platelet.
Thanks very much. Well, we've just heard 2 terrific talks about blood, and we've focused on pre-hospital transfusion of red cells and plasma, and we've heard international point prevalence study of transfusion, and although there was a mention of platelets there wasn't a lot of emphasis on either of those 2 talks, and I think that's what we're all guilty of. When we talk about blood transfusion, we tend to forget the platelets, although I was interested to hear that 18% of the transfusions, or the patients in the ICU were transfused platelets. So perhaps that's not universally true, but it is true in our practice, in civilian practice in Brisbane, that it's commonly the case for patients who've had a lot of bleeding intraoperatively to come through the door of our ICU with a fairly normal looking TEG or ROTEM, having had factor replacement, red cells and so on, but no platelets, and to still be bleeding. And for us to reflect as intensivists that maybe that's not optimal management. And so at the end of the next 10 minutes or so, my invitation to you is to consider whether that is right, and perhaps to not forget the platelets might be a better strategy for patients like that. And in particular, to frame that discussion around trauma. I don't have any funding conflicts of interest. There's no money in platelets, but I do have quite a bit of intellectual, you might say, conflict of interest, as I'm the chief investigator in a number of platelet trials. You've just had here in Europe the release of the European guidelines for management of transfusion coagulopathy in trauma, and platelets here do seem to be a little bit de-emphasised, you might say, whereas plasma and red cells are given grade 1 recommendations. The recommendations related to platelets are relegated to grade 2B, largely because they don't have much in the way of randomised controlled trial evidence. But that's true of a lot of our interventions in medicine, and I'm going to show you that, in fact, there's quite compelling other evidence that suggests that we should not forget platelets. But if I was going to sell the platelet to you, this probably wouldn't be the place to start, at least in trauma. So this is assessing the question of whether, in fact, trauma patients become thrombocytopenic. And as any of you who do clinical practice in this area will know, they don't commonly become thrombocytopenic. This is a large observational study showing that, indeed, in the first few minutes after trauma, the platelet count becomes a negative acute phase reactant. There is a platelet drop, but rarely do the platelet counts go below about 100, the level at which we would consider conventionally a platelet transfusion in a bleeding patient. So thrombocytopenia is not common in trauma, or indeed in massive hemorrhage, unless it is the cause per se. But does platelet count matter? Do platelet counts of above 100 matter? Well, they do seem to. So there's a number of observational studies, here is just one, that plot a really clear relationship between platelet count and in this case, mortality. So as those normal platelet counts fall, below here, as they fall below even 800, or a high platelet count, the mortality increases, even when adjusted for other markers of severity of injury. And why might that be? Well, it's almost certainly because the platelets are developing a platelet functional defect. And this is nicely demonstrated again in a number of observational studies. This one's quite old, but it's a neat demonstration that within a few hours of admission, trauma patients develop abnormal responses, here measured by aggregometry, to a number of different platelet stimuli that remain abnormal for the subsequent few days after admission after trauma. So it might be that transfusing these people who don't seem to be thrombocytopenic with platelets that are more normal in their function might be of some benefit. And if we were to look for biochemical or laboratory evidence for the patients who might benefit most from such a platelet transfusion, you could hypothesise that looking for viscoelastic testing evidence for platelet dysfunction would find those patients who would, at least in theory, derive the most benefit. Because, of course, we know that, again, at least in theory, a TEG or a ROTEM can identify platelet dysfunction from an abnormality in the maximum angle or the maximum clot firmness, which can be distinguished as a platelet function or a fibrinogen deficiency by comparing the functional fibrinogen or the FibTem from the standard trace. I won't take you through how to interpret that. That's, I guess, a fairly standard approach to reading the viscoelastic test. But does that work? Does that really identify platelet function abnormality? Well, the answer is no. It's quite insensitive to platelet dysfunction compared to being really quite sensitive to fibrinogen dysfunction. Or low fibrinogen levels. And here's a nice demonstration of that. So in contrast to platelet aggregometry, which looks specifically at platelet function, TEG here was quite insensitive in revealing the effect of increasing concentrations of tyrofibin, a platelet function inhibitor. So the conclusion of this study was that TEG was quite insensitive to platelet, in this case artificial platelet dysfunction. And so what would you expect then if you introduced a TEG-driven, or in this case a ROTEM-driven algorithm to your hospital? What would you expect in terms of the transfusion outcomes? Well, this is a before and after study that was done in cardiac surgery, actually, not in trauma. But if you introduced a test that was relatively insensitive to platelet dysfunction and sensitive to fibrinogen deficiency, well, you would expect to be transfusing more fibrinogen or cryoprecipitate and less platelets. And that was exactly what happened in our local hospital, cardiac hospital in Brisbane. So, the proof of the pudding, you might say, was in the transfusion outcomes. And that's been true in a number of other clinical trials. So here is another study that randomised people to a viscoelastic versus non-viscoelastic guided transfusion algorithm. And again, the patients who received TEG-guided transfusions had less platelets transfused than if they were guided by conventional coagulation assays. So should we be doing platelet-specific coagulation testing? There's a number of devices on the market, and indeed there are cartridges that work on the TEG and the ROTEM machine that look specifically at platelet function. Well, the answer is probably yes, but as is reflected in your European guidelines released only a few weeks ago, the level 1 evidence, the trial evidence in support of this translating to patient benefit is currently lacking. So it's not really possible to say yet whether that should be the strategy. So summarising so far, and this is in a sense a little bit of a theoretical argument combined with some empiricism. So trauma patients are not commonly thrombocytopenic, so you wouldn't normally give them a platelet transfusion, but nonetheless those low normal platelet counts are associated with a higher mortality. So that might be because of platelet dysfunction, which you're not going to be able to identify on your conventional viscoelastic test. So it's possible that some patients who might benefit from platelets are missing out. Is there any at least observational evidence that that might be true? Well, there's at least some basic science to suggest that it might, because a lot of the coagulation cascade occurs on the platelet membrane. This is, I think, commonly forgotten. We've got to imagine that it happens in the soup of the plasma, but in fact, a lot of what we require to form a clot happens on the platelet membrane. So, in addition to forming the actual physical structure of the clot, we need the platelets to facilitate the enzymatic reactions. But let's look to observational studies. So here is just a retrospective observational study that looked at patients, trauma patients from US civilian trauma centres that happened to receive high ratios of platelets to plasma and red cells versus medium and low ratios. And as you can quite clearly see, there does seem to be a survival advantage that persisted out to 30 days associated with a high ratio of platelets to those other blood components. And that's been replicated in numerous observational studies. Here's one from a military hospital in Iraq, the US military, that again found, a retrospective observational study, admittedly with all its faults, that a high ratio of platelets to red cells transfused translated to a mortality advantage even when adjusted for severity of injury. Again, essentially the same study repeated again from 466 US trauma patients, high ratios of platelets to other blood products, translating to 30-day survival benefit. And then possibly the most convincing study of all, so a better study methodology than just trying to adjust for injury severity is a propensity matched analysis, and that's what these authors did just at the end of last year. US trauma patients looking at 6-hour mortality in a large database, 20,000 patient database, looked at, first of all, platelet counts and found that, as we saw in the initial slide, platelet counts tend to be lower the more severe the trauma is, but rarely do those patients fall below the conventional criteria for thrombocytopenia. What's more, as we saw in the second slide, there was a relationship between mortality and what we would call normal platelet counts. So as the counts go lower, the mortality goes up, even within that normal range. But when adjusted, and in a quite sophisticated way, adjusted for all predictors of mortality, the early platelet transfusion conferred substantial mortality benefit at 24 hours. So, where are we in terms of clinical trials? Regrettably, there are none. But there's one that comes close, and it's a retrospective analysis of the proper study. You remember the proper study, the 1:1:1 versus 1:1:2 ratio study of plasma to red cells. But in this retrospective study that was published sometime after that initial study, they looked at patients who happened to receive platelets in the first MTP pack versus patients who did not receive platelets in that first MTP pack. And this was a quasi-random event. It certainly was not randomised, but there was no systematic bias as to whether this was or was not the case. And as you can see, if you happened to receive platelets in that first MTP pack, there was a substantial mortality advantage, once again, that persisted out to 30 days. So, one little extra point to note is a really kind of small fine print result from the ITACTIC study. So ITACTIC, you remember, randomised people to a viscoelastic versus conventional clotting test guided intervention, showing no difference ultimately in the clinical outcomes. It was a very disappointing clinical trial for those of us who believed that this was going to be the answer for trauma transfusion. But in the supplemental material, you can find that viscoelastic testing increased the incidence of both fibrinogen and platelets transfused, but there was a substantial increase of fibrinogen, much more than there was an increase in platelet transfusion. So that's kind of interesting. It kind of supports everything that I've been saying, that viscoelastic testing is very sensitive to fibrinogen deficiency, but not so much to platelet dysfunction, but curiously did not translate to a mortality advantage. Now, the trial wasn't designed to assess that specifically, but in a sense it's kind of the counter to the argument that I'm making, and I think really just builds equipoise for doing a trial specific specifically of this question. So, that then leads to the question in the last couple of minutes of how we're going to do this. Because platelets have a shelf life of 5 to 7 days. They're stored at 22 degrees, and that increases the risk of bacterial contamination. They can't be stored any longer. But you can store them in other ways. You can store them at 4 degrees, which extends their shelf life to 14 days and potentially even longer. And if you do that, not only do you extend their shelf life, but you potentially pre-activate them, and in pre-activating you potentially increase their hemostatic effectiveness, as was shown in this Norwegian study of cardiac surgical patients that was presented at a conference a few years ago. And this has been spun out now into a much larger randomised controlled trial sponsored by the US military. The other thing that you can do is freeze them in dimethyl sulfoxide at minus 70 to minus 80 degrees. And there's been one trial in cardiac surgical patients of that technology that showed, similarly, that this kind of pre-activates the platelets, leading to less blood loss through the surgical drains and less blood products transfused. The risk, though, is that in doing this, you set up a sort of pro-inflammatory state and potentially expose the patient to risks of ARDS and maybe prothrombotic complications. And this relatively small trial of 73 patients probably would not have been large enough to detect those if indeed that was the case. And so that's led to us in Australia doing our CLIP study. I need to update this graph. We're now more than halfway through our recruitment of 200 patients transfused, and our colleagues in New Zealand, so this is our CLIP study, put together a collaboration of cardiac surgeons, anaesthetists, intensivists, haematologists, recruiting in 12 hospitals around Australia, and then in New Zealand doing exactly the same study with a slightly different protocol to freeze the platelets. They're up to around 50 patients transfused for a target of 200. Because we're using slightly different protocols, we're running different trials, but we're going to harmonise the data collection, or we have done. We're going to put that together in a meta-analysis at the end of the two studies. And then hot on our heels are the Americans, who are doing exactly the same study. We've shared our protocols under a military scientific collaboration alliance, and I'm kind of pleased to say that we're beating them at the moment in terms of recruitment, but at the end of the study they will join that individual patient data meta-analysis as well. And I hope, I genuinely think that this has the potential of revolutionising the way we deliver platelets for acutely bleeding trauma patients and indeed all acutely bleeding patients in the next probably 3 to 5 years. Thanks for your attention.
Thank you. Comment, question? So, as a clinician, do you think that we will have a right way to evaluate the function of platelet at the bedside, or is it a stupid dream?
No, I think it's a very valid dream to have. I think the modern platelet function analysers just need to get a bit more acceptance into practice, and then someone will come along and do a trial that combines both an assessment of the device and an intervention, so a paired trial, if you like, that I think will show patient benefit. So yeah, I think that is on the horizon for sure.
Wonderful. Thanks a lot. If we have no other comment, we will move on. Thank you.
It's my pleasure to announce our next speaker, who is Professor Nicole Juffermans, who is a Professor of Translational Intensive Care Medicine at the University of Amsterdam.
Thank you. Dear colleagues, we live in a great time. We are moving away from the boring binary distinction of just male, females. There is so much more out there. And I was discussing this with my teenage kids, and they have a lot of fluid friends with purple hair, green hair. And I was saying, wow, guys, it's so great. You know that DNA was found, and there's really a biological plausibility for feeling more or less male or female, depending on the penetration of a gene. And my children, they looked at me with horror and said, oh, Mom, that's so really you? Do you really need a biological explanation for gender diversity? And I was saying, okay, yeah, maybe you have a point, but whatever you know, how your mind works or how you were brought up or your cultural background, for sure, their world is way more interesting and complicated than just binary male-female. You may think, where is this going to? It's going here. I'm putting you back to transfusion. We will talk about male-female. And the interest is that the adverse effects of transfusion, which are many. It's related with the acute lung injury. It's related with acute kidney injury. It's related with a prothrombotic state and infections, and in the end with mortality. And we've put, in recent years, a lot of effort in finding the optimal hemoglobin trigger, looking at different patient populations, looking at different organs, trying different physiologic transfusion triggers, and we haven't been very successful. And I would like to pose the question, you know, it takes every kind of people to make this world go round, right? And there's so much diversity out there. It must impact whatever is in the blood bag, given the diversity of blood donors. So what do we know about blood donors? Nothing. And then I got this phone call from this guy, Abdul Rahman Al-Shalani from Saudi Arabia. And he said, I know you are doing research in this field, and I think that there is a signal there from female blood. It may be detrimental, and it may be related to age of cells. I mean, do you feel this? The layeredness in this from Saudi Arabia? Want to talk about female blood? And look at how he looks, right? He really wants age of red cells. It has nothing to do with the storage shelf life, right, of red cells, which is a way different thing. Red blood cells, when they enter the circulation, they mature peripheral blood. So females, they have more young red cells because they bleed every month, and the bone marrow has to compensate. It has to generate young blood cells. So the amount of young blood cells retain all these receptors on their cell membrane, interacting them with endothelial cells and with other cells. So reticulocytes are more immunogenic, and they are different in compared to the receipt of male blood of 6 units or more, with quite a high difference in a very large population. But only looking at mortality as endpoint, okay? But again, this is a registry study with over 32,000 patients, and there, in male recipients. And maybe you would think, pregnant, what has that got to do with it? And again, and also, this does not only speak to female blood, but also to a sex mismatch, which may be more important than the receipt of female blood. So what's this with being pregnant? This has to do with transfusion-related acute lung injury, which is a cause of ARDS. It resembles ARDS in many ways, but it's related to transfusion. And TRALI is a double hit mechanism. So first you have some inflammation going on that primes the neutrophils in the vessels of the recipients. So they sit there really tight, they are waiting to be activated, and activation antibodies due to exposure to a foreign blood circulation during pregnancy, okay? Especially after you have had multiple pregnancies. Resulted in a decrease in the occurrence of TRALI, again underlining the association between antibodies in the donor and the occurrence of TRALI, or acute lung injury. HLA antibodies causing ARDS or TRALI, which then, is a mechanism of increased mortality. But why would this be only in the males? Okay, this is not solved. So, and this was another observational study, again, looking in a large registry, pregnant females, non-pregnant, and males, and they did not find any difference. So there were, observational studies, but not showing the same results. So with Abdul, we had this hypothesis that transfusion of female blood may be bad in ICU, in male recipients. So what we first did is a cohort study in ICU patients, because they are different from the whole population, obviously. We made 4 groups: female to female recipients, female to male, male donor to female recipients. In female recipients had the highest survival, whereas receipt of female blood in males, again, this signal of a decrease in survival. Females and males, which makes sense, right? Not to statistical significance, but a trend, if you will. But this means that the receipt of female blood in the recipients of the males. So then they thought, okay, there has something to do with the sex mismatch, right? Female, male, male, female. So we grouped the patients together. A receipt of a single red blood cell transfusion, and we found an increase in virulence factor, which may indicate a more upregulated or inflamed endothelium issue. On density, because the young blood cells are less dense and less heavy than the old red blood cells. So doing that, we did in vitro studies. We took endothelial cells, we stimulate them. And you can see the incubation with young red blood cells showed a decrease in adhesion marker, whereas the old red blood cells didn't really do anything compared to the control. But again, so we thought we'd take it all together and in an experimental way try to make sense of this. And we used a rat model of transfusion. And we made standard blood of rats, of both male and female rats. And we also made blood products after taking out the blood for a few times. So the rat then starts to make young blood cells. And then we made the blood product, which is then enriched for young blood cells. And male blood enriched for young cells, and then transfuse these into male rats. And the other thing is that we biotinylated the red cells, so we can easily trace entrapment of these red cells in the organs. And here I'm showing you the lungs, but this happened in every organ. We found the red cells trapped it was enriched for young cells because it occurred also with the standard red cells. Okay, and again, we found this in every organ of that we examined. And this was also associated with hemolysis. So the is not the case, and again, irrespective of whether or not the blood product was enriched for the presence of young cells. So with this, I would like to conclude. We're not there. May be regarded as a signal. Of course, these are observations. They're always subjected to confounders that are not controlled for, subjected to bias. The implication is that we should strive for better matching. We should perceive red blood cell transfusion as a mini organ perfusion, because it is a cell.
Thank you very much, Professor Juffermans. I might open out some questions to the floor. Yes, we have one over here and another one there.
I have one. Nicole?
Yeah?
I have one question. Very, very nice and very interesting presentation. So, do you think it's possible in our patient to run a trial? And is hemolysis could be
So first about feasibility. So blood banks are never happy, right? If you say you have to match better, and of course blood banks are responsible for a steady blood supply. So you cannot say, okay, females cannot donate for red cells anymore. I think this would be a huge detrimental thing for the insurance of a steady blood supply. But you could potentially match them, females to females and males to males. I think this is possible. It would need, of course, a lot of logistic around it, but I think it's possible. Whether or not hemolysis can be a marker of, I think if I understand you correctly, the use of hemolysis indicating, so if you have an ICU patient with hemolysis, you would then make the decision to match the blood transfusion? Is that it?
Yes.
Yeah. It's as a kind of a biomarker approach of transfusion, I guess. Yeah, it's an interesting suggestion. I haven't contemplated it. So in my mind, I thought it was an effect of the blood transfusion, that the blood of female bloods adhere to the endothelium, or was in the male environment, let's say to testosterone or something else that causes the female blood to lyse. And then we have this increased hemolysis. So in my mind, it's an effect of the female blood and not a marker up front. So yeah.
We have two questions from the audience, I think.
It's difficult to see.
Did we get a microphone to them? Okay. Any questions? We have one here. Yeah.
My question was, you see difference after how many blood bags one bag of female blood is bag, or you need more than one bag?
Excellent question. It's always the question of the type of blood versus the amount of blood. The patients in the observational study you're referring to, they in average received 2 to 3 blood units only of male recipients. So the patients that excluded blood from both male, or received blood both from male and female donors, we excluded those. So on average they received only 2 to 3 units. So you can imagine if that amount was higher, the effect potentially is also higher.
And I have actually a question. There is a difference if the women had the previous pregnancies or not, because after pregnancies there are generally few little cells of the baby that stay in the blood theoretically for life. So can be a difference if the woman who gives blood is had the pregnancies before or not?
So the association of pregnancy and lung injuries related to the presence of HLA antibodies, that's another mechanism than the age of cells. So females in the reproductive age, they have more reticulocytes, more young cells. Older females do not have this. So again, there also would be an impact not only of the sex of the donor, but also of the age of the female, of the donor, which is a good suggestion to find out, but we haven't really been able to do that due to that you do not, you don't receive any information about the blood donors due to privacy regulations. Difficult.
Thank you, Nicole.